Okay, hello guys, good evening. I hope the voice and video are clear. Okay, welcome to, just give me a minute. Okay. Okay, so welcome to one more Prof Exam Made Easy session. I think this is the fourth session, I suppose. This time we'll be discussing about anti-thyroid drugs. Within anti-thyroids, whenever a question has been asked, very much repeatedly been asked in lots of different examinations, when you come across this kind of a question, they will be expecting you whether you know the pathophysiology behind the thyroid secretion and also regarding the hyper or hypothyroidism. So any questions, mostly thyroid related pharmacology questions, will be asked from in the long answers questions itself. So if in case you land up in a question, I'm going to be giving up to you two important areas. First, I'll be drawing a flow chart to explain the pathophysiology of how actually patients are landing up in hyper or hypothyroidism. And we'll be discussing the mechanism of action of anti-thyroid drug in that same flowchart, followed by your a mind map of a single important one-liners regarding all the anti-thyroid drugs. We'll start from the top. As far as hypothyroidism is concerned, or any thyroid hormone secretion is concerned, the whole process will be starting up from the hypothalamus. Most of you would be knowing it. So here is where your hypothalamus. From the hypothalamus, there will be release of a molecule named as TRH, which is thyroid releasing hormone. This thyroid releasing hormone, which is released from the hypothalamus, will be acting up on the anterior pituitary cells. Consider this is your anterior pituitary cells. On the surface, we have this TRH molecules. It will be binding up with its own receptor, which is there on the surface of the anterior pituitary cells, which is actually a G protein coupled receptor, a GQ coupled receptor. What's the take home point from general pharmacology? If it is a GQ coupled receptor intracellularly, it is going to be stimulating IP-3 and DHE. So because of this TRH, thyroid releasing hormone, which is stimulating intracellular IP-3 and DHE, because of the stimulation, there will be increase in the intracellular calcium levels. This calcium, which has been increased intracellularly, is responsible for the release of certain molecules from the anterior pituitary cells, which is TSH molecules. TSH is thyroid stimulating hormone. So we have two hormones over here. The first one is thyroid releasing hormone. The other one is thyroid stimulating hormone. This thyroid stimulating hormone, which is released, in turn will be binding up with the thyroid cells. We used to call them as follicular cells. So again, we'll be drawing a diagram, guys. Consider here is where your thyroid follicular cells is. Okay. Here is where your TSH molecules, thyroid stimulating hormone. This in turn will be interacting with its receptor, again a G protein coupled receptor, which is a GS coupled receptor. Please note down TRH receptor. TRH receptor is a GQ receptor, whereas TSH receptor is a GS receptor. So what happens whenever GS receptor is getting stimulated? Again, intracellularly, there will be increase in cyclic AMP, which in turn will send the impulse into the nucleus. Thereby, there will be transcription, translation, and protein synthesis. Because of this, there will be synthesis of a particular protein, and that protein is nothing but iodide channels. There will be synthesis of a protein named as two proteins will be synthesized. The first one is called as iodide channels. So what will be its function? As the name itself is there, consider here is where your blood vessel is. So here is where your blood vessel, from the blood vessel, those iodides which are there, I minus which are there inside the blood vessels will be taken up into this follicular cells of thyroid. This is what we call as iodide uptake. This is explained as iodide uptake into the follicular cells. So a small recap: from hypothalamus, TRH will be released, which will be binding up with this GQ receptor, followed by binding up with which is going to be TSH is going to be released out from the anterior pituitary, which will bind with the TSH receptor, which is GS. Thereby, there will be increase in the iodide transport. Iodide will start moving from the blood into the follicular cells. Now, inside this follicular cells, we can also write it up. There will be iodide transport. there will be iodide transport. This iodide which is getting transported into the follicular cells, in turn will be fusing up with the tyrosine residues. If one iodine is being fused, then it will be named as monoiodotyrosine. If two iodines are fused, it will be named as diiodotyrosine. I'm going to be writing up two examples of DIT over here. So MIT, DIT, and DIT. Of course, we know, guys, monoiodotyrosine and diiodotyrosine, 1 plus 2 is going to be 3, which tend to produce T3. Whereas DIT and DIT, diiodotyrosine and diiodotyrosine together will form T4. So T3 and T4 is going to be formed up over there, which is all of these things is happening inside the follicular cells. Now this MIT and DIT, which is getting synthesized, and the formation of T3, T4, this step is catalyzed by an enzyme named as thyroid peroxidase enzymes. This is named as thyroid peroxidase enzymes. Also, it can be called as thyroperoxidase enzymes. Any names if we want to keep. Certain books tend to say it differently. So thyroperoxidase enzyme is responsible for the synthesis of T3, T4, and also MIT and DIT. Now, these molecules which are getting synthesized inside those follicular cells, whenever there is stimulation from the TSH, first point, there will be movement of iodide inside those follicular cells. The second point, there will be release of all stored T3, T4 into the blood, which I'm going to be writing up over here as periphery. Periphery is nothing but the release of T3, T4 into the blood. So we have T3 and T4, which is there inside the blood. Now, among these two, T3 and T4, which is going to be more active inside the body? An important question, guys. Which will be more active inside the body? T3 will be more active, T4 will be lesser active. So there will be conversion of T4 to T3, which is happening in the periphery. 4 iodide is converted to 3 iodide, which means deiodination is happening here. And this step is catalyzed by an enzyme 5-deiodinase enzymes. 5-deiodinase enzymes. T3 is called as triiodothyronine, whereas T4 is called as tetraiodothyronine. Now this T3, T4, not all the T4 will be converted. Most of the T4 will be converted to T3. There will be a ratio, there will be an equivalent ratio between T4 and T3, which is functioning inside your blood. This T3, T4 in turn will be binding up with its own receptors. This is the nature of a nuclear receptor. The nature of T3, T4 receptor is a nuclear receptor. Thereby, it will be responsible for its thyroid-related functions. Simply, there will be increase in the basal metabolic rate. I'm writing up only one thing over here. Multiple other responses will be seen. I'll just corner it up into that. We'll be sticking on to pharmacology as much as possible. So a small recap, my dears. So what exactly has happened over here? From the start, there was release from the hypothalamus. TRH was released, which in turn has binded with TRH receptor, thereby increase in intracellular calcium, which tend to release TSH molecule. TSH in turn will bind with the GS receptor, intracellular cyclic AMP, thereby more amount of intake of iodide inside those follicular cells. This is named as iodide transport, which in turn will bind with tyrosine, monoiodo, and diiodotyrosine, which in turn will be forming T3 and T4, which is released into the periphery. In the periphery, T3 will be more active. That's why there will be conversion of T4 to T3 in the periphery, which is named as 5-deiodinase enzymes, which in turn will bind with the nuclear receptor. Thereby, it will produce the thyroid-related functions inside the body. Now, what are all the anti-thyroid drugs which we currently have? The first most important one, which is used in practice, is your thioamides. In some books, they used to call them as thionamides, and thing is going to be thioamides. We'll be giving you a flow chart, or we'll be giving you a mind map to explain about the pharmacology of these drugs. We have thionamides. These drugs will tend to inhibit this thyroperoxidase enzymes. Thyroperoxidase enzyme will be inhibited by this. Just give me a minute. Okay. Thioperoxidase enzyme will be inhibited by thioamides, the first drug's mechanism of action. Apart from that, we also have a drug named as propranolol, the beta blocker, which is commonly being used in practice for thyroid storm. A sudden increase in the thyroid levels, which might produce tachycardia, thereby produces arrhythmia. To prevent that from occurring, we might use propranolol for that treatment. We also have a drug which is propylthiouracil, which is actually one of the thioamides, and amiodarone. Three drugs are there currently: propylthiouracil, propranolol, and amiodarone. All these drugs tend to have additional inhibition of 5-D iodinase enzymes. What exactly is propranolol? It's a beta blocker. Propylthiouracil, it is a thioamide molecule. What about amiodarone? That is an anti-arrhythmic drug, class 3 anti-arrhythmic agent, which is actually a potassium channel blocker. Apart from potassium channel blockade, it also has multiple other channel blockades too. We'll discuss more about that under anti-arrhythmic agents. So three drugs which tend to inhibit the peripheral conversion of T4 to T3, or we can call them in one another terminology, drugs which might inhibit 5-D iodinase enzymes. We also have one more drugs named as anions. Anions, what are those anions? As the name itself implies, anions are those drugs which are also negative charged molecules. So what will happen is, if they are negative charged molecules, that will inhibit this iodide channel, or simply iodide uptake will be inhibited by anions. So simply, instead of this I minus, there will be some other molecules which are also negatively charged that will compete with the iodine which is gaining entry into the follicular cells. Because of that competition, this iodide cannot gain entry into those follicular cells, which tend to inhibit iodide transport. We also have certain drugs called as iodides. We'll discuss about the proper iodide itself that will decrease the synthesis and release of thyroxine. We also have radioactive iodide, which is primarily been used as an adjunct for surgery. If we can't do surgery in some patients, we can opt for radioactive iodide. Right. These are the different drugs which we have currently, which is used in practice. What are the drugs? Small recap. Thioamides. What is the mechanism? It tend to inhibit thyroperoxidase enzyme. Then we have propylthiouracil, amiodarone, and propranolol, the beta blocker, which tend to inhibit the peripheral conversion of T4 to T3. And the last one, anions, which tend to inhibit iodide transport. Thereby, it will be utilized as an anti-thyroid drug. Now, let's talk about the pharmacological perspectives of these drugs. What are all the drugs which we currently use in practice for hyperthyroidism? See, as per hyperthyroidism, here I'm writing HT. HT stands for hyperthyroidism. Don't remember it as hypo, it is hyperthyroidism. Hyperthyroidism treatments, we have 4 important drugs. As I've told, we'll be drawing a mind map to explain about the pharmacological perspectives of all these drugs. Again, this is just like a notes, guys. You just need to take down these notes, and just before the exams, you just need to recall it. You just need to recap it. Mostly within like 50 pages, maximum 50 pages, you can cover up the whole of Pharma, all of these things written in mind maps and flow charts. Just as a quick revision, and after that, you go for the exams, and you're going to be scoring up like at least like 50-60% more than what you have gotten before. Let's start with the first drug. The among thioamides, we have thioamides, we have anions, proper iodide itself, and radioactive iodide. 4 drugs which are used currently for the treatment of hyperthyroidism. HT is not hypertension again, this is hyperthyroidism. Okay, what about the thioamides? What are the classical features of these molecules? We have 2 drugs, which is propylthiouracil. We have discussed that already. The second one is named as carbimazole. Propylthiouracil, carbimazole. And also we have a derived drug named as methimazole. Carbimazole is the prodrug of methimazole. So both are actually one and the same. What are the points which you have to remember regarding this carbimazole and propylthiouracil? Please note down that these molecules I'll write down separately. Okay. Please note down that these molecules, out of all this, if a patient is there in first trimester of pregnancy, propylthiouracil is the only drug which can be safely administered. If the patient is moving on to second or third trimester of pregnancy, methimazole or carbimazole can be administered. Now comes the famous question, why can't we administer carbimazole or methimazole in first trimester of pregnancy? And why we usually don't administer propylthiouracil in second or third trimester of pregnancy? Two important questions we have to find out the answers for. The first one, propylthiouracil, which we have discussed, it is better given during the first trimester of pregnancy. Hi Tarun, good evening. Hi. Okay, propylthiouracil, which is given during the first trimester of pregnancy, usually is not preferred to be continued during the second or third trimester. Why? Because propylthiouracil itself might be producing severe hepatotoxicity and aplastic anemia. Severe hepatotoxicity and aplastic anemia, which is more with propylthiouracil. So we can't ask the patient to continue taking propylthiouracil during the second or third trimester. Even if you want to continue propylthiouracil, we have to regularly monitor the complete blood count values so that we can early pick up in case the patient is landing up in anemia. And we have to regularly monitor the LFT values to find out whether there is any increase in the liver enzymes like AST or ALT. What about methimazole and carbimazole? These drugs cannot be given during the first trimester of pregnancy. These are contraindicated in first trimester of pregnancy because these might be associated with one particular adverse event named as aplasia cutis congenita. Aplasia cutis congenita. Simply, there will be a lack of skin development in the scalp. Okay, what I am having is lack of hair development in the scalp. That is alopecia. That's different. Okay, this is skin development in the scalp that will not be there in the scalp, and that is what explained as aplasia cutis congenita. That will be seen whenever a patient is administered methimazole or carbimazole during the first trimester of pregnancy. Please note down that this methimazole carbimazole also will be producing the same hepatotoxicity and aplastic anemia. But the severity will be lesser with the methimazole carbimazole as compared to your propylthiouracil. Okay, these are the classical features about thioamides, and we have discussed already what is its mechanism of action. It will inhibit thyroperoxidase enzymes. We'll move to the next one, guys. Anions. What are the anions which we know? We have perchlorate, fluoborate, thiocyanate. As we have explained already, this is just a simple logic, my dears. These are all single negative molecules. Borate, chlorate, cyanate, these are single negative molecules. It will compete with the iodide entry. Because iodide cannot gain entry, these molecules will inhibit the iodide transport. That is its mechanism of action. It will inhibit iodide transport. Okay. Moving on to the next drug, proper iodide itself. See, iodide molecule itself, whenever it is getting administered, that will produce something called as, you would have learned it from your physiology, guys. Two important phenomena. One is called as Jod-Basedow effect. The other one is Wolff-Chaikoff effect. Okay, we have two important effects right now, Jod-Basedow, Wolff-Chaikoff. Can anyone know what exactly, which is responsible for production of like increase in thyroxine secretion, which is responsible for a decrease in thyroxine secretion? Some people will be having a doubt, so having a confusion about which will be responsible for increased thyroxine, which is responsible for decreased thyroxine. I'll give you a simple clue to remember it, my dears. Wolff-Chaikoff effect, remember this, OFF. Wolff-Chaikoff effect means the effect will be lost or T3, T4 levels will be decreased. With that, we can easily remember it. When you administer too much amount of iodide molecules for the patient, because of a response named as Wolff-Chaikoff effect. Wolff-Chaikoff effect, there will be decrease in the thyroxine secretion. That's why this iodide will be named as thyroid constipating agent. This is also explained as thyroid constipating agent because that will decrease the thyroxine secretion. Iodide, when do we use it, my dears? When do we use it? Just before surgery. For example, a patient is diagnosed with goiter or hyperthyroidism, that is a bigger swelling which is there just below the chin. and you have diagnosed the patient as hyperthyroidism, the patient is about to be posted for surgery. Whenever the patient is posted for surgery, there might be increased vascularity. Whenever you are cutting out the thyroxines, there might be profuse bleeding, point number one. Number two, these glands which are there inside the neck might be lax, right? It might be very much flabby. It is very much difficult to find out the border of those thyroid glands. So to make the gland firm and less vascular, before surgery, it might be subtotal or total thyroidectomy, anything it's going to be. Before surgery, to make the gland firm and less vascular, we start administering iodide at least like 2 weeks prior. Only then the glands will be very much concise, it will be firm, we can easily take it out, and it will be less vascular. The bleeding sensation also is going to be very much lesser in those patients. Okay, these are the classical points about thioamides, then explained about anions, then we explained about iodides. What about the last one, radioactive iodide? Here, what are the classical features of it? See, you would have seen a movie called as Troy, right? Most of you would have seen the movie, a very famous movie called as Troy, but even if you don't know, don't worry. See, there will be two countries which are fighting up with each other, right? The first country is there and the second country. The first country will go towards that country and try to gain entry into that and kill off, but they can't do it because this country is protected by a bigger wall. A big wall is surrounding that country, which is preventing these guys from gaining entry into those. So what happens, this guy, this king, will come and meet this king, and he will gift a bigger wooden horse, right? Of course, you'd have known it, Trojan horse. A big wooden horse will be gifted by this king towards that king, and they will come at peace, right? Like how we have US, which is coming up into the other issues. They're giving like a wooden horse has been gifted up towards that, and this wooden horse is called as Trojan horse. It will be taken up inside as a gift. It will be taken up inside the country. Inside the wooden horse, the warriors will be there. During late night, they will come out of that horse and they will start killing up those whole city. The same concept is called radioactive iodides. This is not a normal iodide, guys. It is radioactive iodide. Whenever it is administered in the patient, it will not be activated. It will be, first of all, uptook into the thyroid gland via the same iodide transporter. Radioactive iodide gains entry into the thyroid gland. And this thyroid gland will not identify it as radioactive or a normal iodide. It will just keep it as an iodide. Tyrosine will start fusing on the surface. Once tyrosine comes and fuses on the surface, it will start emitting up rays. And what are those rays which are emitted up from that? Beta and gamma and sometimes X-rays also will be let out from this radioactive iodide. Now, because of it, what happens, there will be damage, there will be killing of those thyroid cells, follicular cells. But what about those vesicles which already contained stored T3 and T4? Yes, that will be sudden release of all stored T3, T4 into the blood. That's the reason why there will be an initial thyroid storm. There will be initial thyroid storm followed by permanent hypothyroidism. It will not produce just hypothyroidism, guys. There will be initial thyroid storm. See, radioactive iodide, it will take a longer amount of time to see the responses. So whenever radioactive iodide is administered for the patient is admitted in the ward, and the patient will be under constant monitoring of the heart rate. Right, the heart rate will be normal, but after like 3 or 4 days of time, we can see the heart rate slowly rising up. When the heart rate is slowly rising, it means the radioactive iodide has started producing the response. T3, T4 are getting gushed up into the blood, and now we are actually about to see thyroid storm in the patient. In those conditions, what is the drug of choice, guys, for thyroid storm? For thyroid storm, what's the treatment of choice which can be given in those patients, guys? First of all, we have to administer a beta blocker, especially propranolol. Propranolol is the drug of choice in those conditions. Or we can also opt for esmolol. That will be the immediate treatment of choice to safeguard the patient, because patients might die because of this particular thyroid storm. And why is the patient dying? Because of arrhythmia, which is developed because of increased thyrotoxicosis. Patients might land up in arrhythmia. Now, what if a patient is a known case of, KCO stands for known case of bronchial asthma? When a patient is a known case of bronchial asthma and the patient has been administered radioactive iodide and the patient has landed up in thyroid storm. Now, how do we treat that? Why am I asking that is because propranolol is a drug which is contraindicated in bronchial asthma. So in those conditions, diltiazem will be the drug of choice. Diltiazem, which is a calcium channel blocker, will be the drug of choice in those conditions. Second drug, we can opt for thioamides, which is proper treatment of the conditions. Out of this, we prefer to give propylthiouracil. Now, again, what if the patient is a known case of liver failure? What if the patient is a known case of liver failure? Because we know propylthiouracil might be producing severe hepatotoxicity. In those conditions, the drug of choice would be carbimazole or methimazole. In those conditions, the drug of choice would be carbimazole or methimazole. So if a question comes, which of the following is the drug of choice for thyroid storm, the answer would be propylthiouracil. But if the question is known case of liver failure, drug of choice, then the answer would be carbimazole or methimazole. Which of the following will prevent the arrhythmia due to thyroid storm? Propranolol. Known case of bronchial asthma, to prevent arrhythmia due to thyroid storm, diltiazem will be the drug of choice. We can also after administering these drugs, we have to wait till 1 hour. After 1 hour, we have to administer iodine drops via per oral route. Iodine drops is given via per oral route. Again, that is going to be a lifesaver one. If a patient is landing up in severe responses, we can also opt for glucocorticoids, or even simply steroids can be administered, especially hydrocortisone is given via IV route. We can also administer cholestyramine. Remember these 5 drugs which have been used for thyroid storm. The first one regarding beta blockers and diltiazem. Second one regarding propylthiouracil and carbimazole. Third one is iodine drops, glucocorticoid or steroid infusion like hydrocortisone, and cholestyramine. All of these will be the drug of choice in treatment for thyroid storm. So a small recap, my dears. What are the things which we have discussed till now? We discussed about the flow chart which we have to draw regarding hypothalamus, TRH from TRH, TSH is getting released. From TSH, iodide transports, thereby thyroperoxidase, T3, T4 release into the periphery, again nuclear receptor. What are the drugs and what is its mechanism of action? We have discussed about that. See here, propylthiouracil is a drug which has got additional mechanism of inhibition of peripheral conversion of T4 to T3. That is the reason why propylthiouracil is the drug of choice in thyroid storm. Carbimazole or methimazole doesn't have this response. That's why we don't use that as the first treatment of choice. We always keep it as a second treatment of choice only. Then we explained about that mind map regarding all the drugs used for hyperthyroidism. Thioamides and its classical features, we explained it with a single lady who is pregnant from first trimester towards second or third trimester. Anions, what is its mechanism? And iodides, as we have told, Wolff-Chaikoff effect. And radioactive iodide, how it is producing initial thyroid system followed by permanent hypothyroidism. And followed by the last one, how to treat a patient with the thyroid storm and what are the different drug of choices for individual conditions. With this, we complete the drugs which is used for hyperthyroidism. Please make sure that you draw this mind maps or the flow chart, particularly in your exams, that is going to be fetching up X and max as possible. Good night, guys. We'll see if we'll meet up in one more Prof Exam Made session. Good night.